Welcome everyone to the Leukemia and Lymphoma Society of Canada's training called Optimizing Sexual Health and Intimacy After a Cancer Diagnosis, Part 2. This training is geared towards healthcare professionals in our communities. In Part 2, Reanne Booker will address strategies to help optimize sexual health and intimacy and resources for oncology nurses. Let me introduce myself. My name is Natasha Sani, and I'm the Community Service Lead for BC. Before we begin our main presentation, I'd like to share with you our mission and highlight some resources that might be helpful for you and your patients. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by blood cancer and their families. Ultimately, we're here to serve the community. We offer guidance and support to people affected by blood cancer every step of the way. We offer you a continuing education program that you can join freely. Last year, we sent a survey to hematology oncology healthcare professionals around the country. A need for training on blood cancers has clearly been identified. You can register to one or more of our trainings that you can do at your own pace and receive an electronic proof of participation as well. Our educational tools are offered in a variety of formats, from podcasts, animated videos, fact sheets, and more. And these are aimed at different types of audiences. For example, here we have fact sheets on communicating with your healthcare team, fertility and cancer, or supporting your loved one following a cancer diagnosis. All of our materials can easily be downloaded or ordered through our website. Our process is very simple. With this handy electronic form, you can order materials to be shipped directly to your location with just a few clicks. If you have any questions, please reach out to your community service leader in your region, and we're always happy to help. I would also like to highlight our LLSC Health Manager app. It's a great free resource and is available in both French and English. The app helps patients track side effects, medication administration, and offers a food and hydration journal. The app also helps to offer medication reminders and has a nutrition meal planner along with many recipes to help patients get the nutrition they need. The app also allows access for a caregiver and is free to download in the App Store on both Apple and Android devices. Emotional and practical support is important for the LLC. Our peer support program has been identified as a key service, but many do not know about it. Volunteer survivors who are at least 1 year out of treatment are selected and trained and share their stories with newly diagnosed patients or those facing a new treatment option. We match individuals based on age, gender, diagnosis, and treatment. This program helps to build hope, alleviate anxiety, and creates realistic expectations. We also offer a virtual support program from coast to coast that are professionally facilitated. Our group support gives the opportunity to the blood cancer community to connect with others who are facing the same challenges in the comfort of their own home. Each participant can build connection through group discussion, sharing coping methods, information sharing, and helps break isolation. You can visit our website, www.bloodcancers.ca, for more details. It's now time to introduce you to our speaker, Reanne Booker. Reanne is an oncology and palliative care nurse practitioner with over 20 years experience in nursing. She works with the palliative and end-of-life care services program in Calgary, Alberta, and is a PhD candidate at the School of Nursing in the University of Victoria. Her clinical and research interests include the integration of palliative care and oncology, sexual health and cancer, advanced care planning, medical assistance in dying, cannabis and cancer, global oncology, and health equity. Over to you, Reanne.
Well, hi, everyone, and welcome to part 2, optimizing sexual health and intimacy after a cancer diagnosis. So as before, as I mentioned, I don't have any relevant conflicts of interest to disclose. I have received some funding for my PhD studies and research from these institutions and organizations here. And so the objectives for this part of the presentation are to discuss strategies to help optimize sexual health and intimacy after a cancer diagnosis, and to share some resources that oncology nurses can help can use to help address and manage patients' sexual health concerns and intimacy concerns. So I think it's really important to acknowledge that sexual health concerns very often are comprised of biopsychosocial factors. And so implementing or adopting a biopsychosocial approach to managing sexual health concerns is really important. As I mentioned in part one of this presentation, when we did have our sexual health clinic at our cancer center, we had a psychologist that was involved in the clinic, at least one, sometimes we had two psychologists, and then we had the medical management and the ability to assess and manage things from a biomedical perspective. But I will say that it's very difficult to tease out one versus the other, because the biology part and the medical part are so intertwined with the psychosocial part. And so to me, I really felt that that biopsychosocial approach was really essential. This is a diagram that Dr. Daniela Whitman, she's a psychologist or a social worker. I'm sorry, Dr. Whitman, I believe social worker, has created, and really again shows that interplay between the biopsychosocial components. So you can see from the biologic piece, there's hormonal alterations, changes in body integrity, scarring, etc. Interpersonally, there can be relationship issues, communication issues, sociocultural concerns, psychosocial concerns as well. And then in the center here, the cancer-specific problems. So when we think about managing altered sexuality and sexual function, I will always advocate for early assessment as part of quality comprehensive care. If we can educate patients and partners early on as well about ways to maintain intimacy, that can be very helpful. As much as we can, providing support and assistance for the partner to retain their role as partner rather than taking on too much of that caregiving role. We see this very much after hematopoietic stem cell transplantation, when it's often the spouse that is caring for the spouse or the partner that's caring for the patient, and very often has to take on a lot of medical related tasks, medication management, assessing and monitoring for complications. This will also be the case after chimeric antigen T cell receptor or CAR T cell receptor therapy, where there's that very intense periods post-treatment where we're watching for complications. And so really providing assistance there for that partner to retain as much of the partner role. I will always advocate again for psychology and counseling. There's non-invasive approaches that we can use. I'll get into that in a minute. Managing cancer-related symptoms is key as well. And then various specific medical interventions, including referrals to specialists as needed. This paper came out in 2016, and I thought it was really a great paper. Now, you may know that I'm a palliative care clinician, in addition to being someone who's quite interested in sexual health and sexual function and management for patients. And there really is this alignment between how we communicate in the palliative care context, as well as how we communicate with patients about their sexual health concerns. So again, I'll make the case and I'll say, I think oncology nurses are ideally suited to help manage patients' sexual health concerns. And certainly that interdisciplinary and team approach can be really key as well. So engaging and enlisting the assistance of the psychologist or social worker, really having these, expert communication skills, spending time with patients. So, in palliative care, we often have that luxury of being able to spend time with patients, and then being really careful to manage symptoms, because symptoms can really interfere with sexual function and intimacy. So if we're really careful with intensive symptom management, we can really help to alleviate a lot of the concerns our patients have. So what do you say? How do you communicate about sexual health with patients? And, I typically will start with open-ended questions. It's really common for patients to have concerns about sexual function or sexuality after a cancer diagnosis. Has this been a concern for you? Sometimes it might fit when you're talking about patients' goals and wishes and what they're hoping to get out of treatment and what their, concerns are in terms of side effects and things that they're not willing to trade when we're considering treatment and making decisions about treatment. So things like, and this is the PLICIT model that some of you may be familiar with. So number one, offering permission. And again, this aligns very much with the serious illness conversation guide when you're kind of setting the stage and saying, you know, many patients with similar conditions have concerns with sexual function. Has this been a concern for you at all? And then providing limited information. So things like treatment side effects often have a big impact on sexual activities. How's your experience been? And then moving to more specific suggestions. And again, this may not be something that all nurses are comfortable providing, but if you've got resources in your cancer center that you can refer patients to, or different handouts and things like that. But here would be things like providing information about vaginal lubricants and moisturizers. And then intensive therapy, I would say, would be reserved for those that are more specialized in managing cancer related sexual health concerns. And so referring to perhaps a psychologist or counselor or a clinician that's specialized in this area. And then in terms of helping patients and partners talk about their sexual health concerns. So, you know, again, a lot of patients and partners, this won't be familiar for them. So a lot of patients and partners won't have discussed sexual health necessarily in their relationship. And so just really helping them with this communication piece, you know, again, planning ahead, taking it slow, being patient, being forgiving to one another. And then Dr. Lauren Walker and Dr. Richard Wassersug and Dr. John Robinson have come up with these questions that patients and partners may want to ask each other. So, you know, things like, what about, what do we do if one gets aroused and the other doesn't? Or how do we feel about bringing in treatment for erectile function concerns or sex toys or different devices? What feels good? What doesn't feel good? Those kinds of questions might be helpful for patients and partners to discuss with one another. Oh, my apologies. There we go. So improving intimacy. So again, I'll make the case that when we talk about sexuality and sexual function, it's not always about sexual intercourse or even about sexual activity, but that physical and emotional intimacy piece can be really key. So, you know, in our clinic, we would talk about emotional, sensual, and sexual intimacy. Sometimes it is, you know, doing a massage with each other or cuddling or dancing or taking a bath together and that kind of thing. Essential, that would be the sensual activities, and then non-intercourse sexual activities, outer course or other course, or very erotic non-insertive sex. And then again, specialized exercises. And so in our clinic, of course, having had the psychologists with expertise and training in this area, they were able to do something called sensate focus, where, you know, you take intercourse right off the table, and it's a series of over, you know, 5 to 6 weeks. The patient and partner would explore each other's bodies, talking, and week 1 would be no touching of genitalia or sensitive body parts. It's just more about getting comfortable talking to each other about what feels good and what doesn't. Maybe there's a scar tissue or area on the body that's very sensitive to touch, that doesn't feel good being touched. And so it would be an opportunity for the patient and partner to really talk about what feels good. And then as the weeks progress, it can become more, you know, explicitly involved in touching certain areas of the body and that kind of thing. But holding off on intercourse until the very end of this exercise, the sensate focus, which might be 6 weeks into it. And for a lot of the patients that we had seen, we did talk about taking intercourse right off the table, because it may have been that there were erectile challenges that were causing significant distress for the male partner. Or it could have been that the vulvovaginal changes were so significant and causing so much pain for the female partner that we really needed to work on improving the vulvovaginal health first, and not pushing it too much, because that would just cause more distress. And so we talked about other ways to help patients, you know, be able to talk about what felt good and not, and other ways to help each other experience sexually related pleasure that didn't involve sexual intercourse. And improving, pardon me, improving desire. So again, that awareness that there may not always be spontaneous desire. So that might be because of fatigue or symptoms or pain, that spontaneous desire might not be there, but that you can still go on to have an enjoyable sexual experience, even in the absence of that spontaneous desire. So it might start with cuddling or massage or something like that, and then that might lead to desire, or that might not be there at all. But really having that awareness and discussing that just because that spontaneous desire piece is missing, it doesn't mean that you have to abandon sexual activity altogether. Certainly, I think counseling plays a role here too, and mindfulness-based meditation can be very helpful with this desire piece. There are lots of different ways that we can help with erectile function. So first off, in our clinic, we would always want to try to figure out as much as we could what the reasons were for the erectile function, because some of the strategies and interventions are better suited for certain types of erectile function caused by different things. So for example, if there's very bad nerve damage, the medications like Viagra and Cialis don't tend to work as well if there's bad nerve dysfunction. So yes, there's an array of different things we could do. Probably the most common that most are familiar with would be the medications. And then there's different things. So external penile prosthesis or strap-on. The elator is a custom-made device that is made specific to the dimensions of the individual patient. It's made in the US. It costs about $300 to $350 US. And you can see how it works there. It's a semi-rigid kind of material that would help to stretch out and help the penis be in a semi-erect position. Constriction rings, vacuum erection devices, injections and implants. I'll get into a little bit more detail going forward here. So the medications, so phosphodiesterase type 5, PDE5 inhibitors. In Canada, we've got sildenafil, which is Viagra, vardenafil, Levitra, or tadalafil, Cialis. In the US, they've got Avanafil. We don't have that yet in Canada, to my knowledge. The benefit of that medication, it's got a very, very short half-life. And so you can give nitroglycerin or nitrates in proximity to receiving these medications. So, or to receiving Avanafil specifically. For the others, it is considered a contraindication because giving these medications with nitroglycerin or nitrates can cause a very low blood pressure. So it's potentially a little safer to give a nitrate, after someone's had Avanafil, but we don't yet have that medication available in Canada, to my knowledge. All the medications work very similarly and have similar side effect profiles and efficacy. They basically work by increasing cyclic GMP in smooth muscle cells of the penis that then leads to smooth muscle relaxation and increased blood flow into the corpus cavernosum. So you can see here how they work. They take about 30 to 60 minutes to kick in. So there's some planning that's required. Some patients don't like that in terms of, it reduces the spontaneity. So with tadalafil or Cialis, there is the option of the lower dose. So a normal dose of tadalafil would be 10 to 20 milligrams PRN, 30 to 60 minutes before sexual activity. In contrast, somebody could choose to use tadalafil 5 milligrams daily, just taking it with all their other meds. And then that would allow a more steady state of tadalafil in their system. So they could then go on theoretically to have a sexual encounter and not have to take something 30 to 60 minutes beforehand. So it doesn't require as much forethought or planning. Tadalafil on the PRN side of things, tadalafil's got a longer half-life than vardenafil or sildenafil. It's the so-called weekender. It doesn't mean that the patient would be in the upright position all weekend. It just means that there'd be enough of that drug still in the system that should they embark on a sexual encounter, there should be enough of that medication in the system to result in an effective outcome. What else to say about these? So the class-related side effects, there can be headache, there can be some facial flushing. All of these side effects tend to be fairly mild to moderate. We didn't ever really see any significant side effects in our clinic. You can try rotating to a different medication if there is a side effect that arises with one, but there's a good chance that they'll have that same side effect because the mechanism of action is similar. The other thing, as I mentioned before, is that we really need to know what the reason or mechanism underlying the erectile function challenge or challenges is or are. So if there's really bad nerve dysfunction, then these medications may not work. And similarly, if there's very low testosterone or the patient is hypogonadal, these medications may not work. That being said, it's a fairly non-invasive, fairly reasonable and I won't say palatable, but I'll say that a lot of men were not dissuaded from trying this because it's not a difficult intervention for them to take. But I will also say that most drug insurance plans do not cover these medications, so there's some cost involved as well. Intracavernosal injection therapy is another option. So I did teach men to do this. We taught them how to do their first dose in clinic, and it would either be the man or the partner to give the injection. It's a tiny needle, so like a diabetic type needle, very tiny, and injecting into the lateral aspect of the penis, avoiding any of the major vessels, of course. And we would inject a medication that then gets absorbed into the corpus cavernosum that leads to erection. So the benefit of these medications or this approach is that the injection bypasses the need for neural input of nitric oxide. So patients who have neurogenic type erectile dysfunction, such as after prostatectomy or other really bad nerve dysfunction, they may still benefit from these injections. So the efficacy is in the neighborhood of 85 to 90%. But you can imagine it's not the first line therapy because it is somewhat invasive and not, I would say most men are not keen on injecting into their penis. But for those who've tried other options and they haven't been effective, this is something that can be taught. Again, the medication is not typically covered and can be quite expensive. So that is something that I also always make sure I counsel patients about. Transurethral therapy, so the medicated urethral system for erection or MUSE, involves applying a medication into the urethra that then gets absorbed into the corpus cavernosum. The efficacy is in the neighborhood of 20 to 40%, so it's not as effective as the injections, but can be effective for some. We did not use this in our clinic very often because we found we had better success, or we had good success with the other interventions. So we didn't use this one. In my experience, I'd actually never used it for a patient, but I have heard from others that it can be effective for some men. Vacuum erection devices. So how these work is they essentially will pump blood into the penis, and then a constriction ring is placed at the base of the penis to keep that blood in the penis, allowing for the erection for sexual activity to occur thereafter. I'll say that patients really need to be counseled. They need to get a good quality medical grade device, and that can cost in the neighborhood of $200 to $400 or so. But there's lots of different devices available online and at sex toy stores and things like that are not always good quality. And you really do need a good quality device to get a good seal and to result in good results. And they can be very effective. So efficacy is in the neighborhood of 90 to 100%. So that's definitely a good option for some patients. Does require some manual dexterity, and again, kind of takes away the spontaneity. For some men, that was seen as a downside. It can be seen also as quite a medicalized approach that can take away from the spontaneity and the intimacy in some ways. So not for all, but I have heard from many men that they do like this option, and it does work quite well. And then I would say kind of the last resort would be penile implants. And these are surgically implanted. So that's why they're not a first line approach. But there's different types. So there are the types where there's a reservoir that's either placed in the scrotum or in the abdomen that can be pumped up, and then fluid then goes into a cylinder that's in the penis and causes a temporary erection. And then it can be deflated after the sexual activity. Or the other option is that there's a semi-malleable rod that's placed, and then the man can then adjust the penis to the desired angle. So these options are very effective in the neighborhood of 95 to 100%, but they do need surgery to be implanted. Most, if not all, I believe all provinces do cover this through their provincial health services. But again, it's surgically implanted, so there can be complications just like any surgery. So this would not be a first-line approach. Managing ejaculatory changes, again, I think just education and awareness. And again, we wouldn't expect to see this a whole lot with our blood cancer patients, but having, discussion with the partner and the patient, education, awareness for things like climacturia, where there's urine that leaks out at time of ejaculation. We can also use that constriction ring at the base of the penis, condoms, pelvic floor physio. All of these options can be quite helpful in managing climacturia. Again, changes in orgasm are a little bit more difficult. There's not been a lot of studies done on orgasmic dysfunction after cancer. So, really, again, here I see a significant role for counseling and psychotherapy. Mindfulness based meditation strategies can be helpful. There have been some studies that have been looking at or have looked at penile vibratory stimulation. This would be mostly in the context of prostate cancer, but seeing if that might be able to help with orgasm. Medication, again, this has been studied mostly in the prostate cancer population with not very profound results, I would say. So somewhat equivocal in terms of effectiveness. So at this time, we don't typically recommend any medications for orgasmic function. Rather, what we would do is try to help those other aspects of the sexual response cycle. So, if there's painful intercourse, if there's challenges with erectile function, if we can help fix some of those other aspects, then sometimes we can find that leads to improvement in orgasmic function. And so for managing vulvovaginal symptoms, again, we want to figure out what the reason or reasons are for the symptoms. I strongly feel that there's always a role for counseling and psychotherapy, and then things like moisturizers, lubricants, dilators, vibrators, pelvic floor physiotherapy for men and women can be very helpful. Local vulvovaginal estrogen if there aren't any contraindications. And then there's some newer therapies that have just been approved in the last few years in Canada. So a lot of people don't realize that vaginal moisturizers and lubricants are different. So moisturizers, just like you would moisturize the skin on your face, they're meant to be used regularly to help maintain the health of the tissues. They are administered typically by an applicator or as a suppository or a gel or a cream. They're meant to hydrate the vaginal tissues and improve vaginal pH and vaginal tissue health. They need to actually be applied not just inside the vagina, so intravaginally, but also to the vulvar tissues. So the outside and the clitoral area. So all those areas, and especially the opening to the vagina, the introitus, all those areas need to receive moisturizer. They need to really be used a few times a week at least, and for up to 3 months before optimal benefits seen. So sometimes we would start patients on these or recommend that they start these, and they would try them for a week or two, and then they would stop because they didn't see any benefit. We really need to make sure we're telling patients that these have to be used 2 to 3 times per week at least for at least 3 months before we'll see optimal benefit. There have been some studies looking at head-to-head moisturizer use with vaginal estrogen, showing similar results. Estrogen perhaps slightly better at managing the vulvovaginal tissue health, but these products can be very effective when used diligently. There's a variety of different products on the market. Sometimes some will have preservatives and different things in them that can be irritating to the tissues. And so then we advise patients to try something else. So in contrast, vaginal lubricants, they're meant to be used to help manage the symptoms. So more as a Band-Aid solution, not fixing the problem. But they can be very effective for sexual activity, intercourse, and even for pelvic and gynae exams if needed. We recommend in our clinic, or we did recommend in our clinic when it was running, to use water and silicone-based. So water-based will wash away more easily, but it doesn't last as long. Silicone-based lasts a bit longer, but sometimes can stain sheets and stuff like that. Again, we counsel patients about the products containing different preservatives and things. So we encourage them to not give up if they try one and it's irritating, to consider trying something else. So preservatives like propylene glycol can be irritating. Things like glycerin, glycerol, sugars and flavors can sometimes be irritating. Anything with a lot of sugars or glycerol, there can be sometimes concerns with yeast infections. So again, we counsel patients to just, try different things, see what works for them. I know that you can buy a case of Replens at Costco, but I would encourage people not to go out straight away and buy the case until they know for sure that that product works for them. You can use vitamin E as a moisturizer and even as a lubricant as well. So patients can puncture the vitamin E capsules with a little pin and squirt out the liquid. Again, here, this is where it's very individualized and unique to some patients. Some patients don't necessarily like touching their vulvar and vaginal tissues themselves. So there can be applicators that they might find to be a little easier. In contrast, other patients might not like the applicators. Sometimes the applicators are irritating and hard, and it can be a bit uncomfortable inserting. So it really is a matter of finding what works for the individual patient. There's some examples of different lubricants as well. And vaginal dilation, historically, this is something that was recommended more for patients who were having pelvic RT, especially for brachytherapy patients once the treatment was done. But we have seen utility of vaginal dilation in various contexts, irrespective of the type of cancer and treatment. So again, especially if a patient hasn't had sexual intercourse in a long time, using graduated vaginal dilation can help a woman gain some confidence and figure out again what feels good and what doesn't. The dilators we give out at our cancer center to patients free of charge are the Syracuse dilators. They do the trick. They come in different sizes, but they're made of a firm material. It's quite hard, and they're not particularly tapered at the one end. So there are other products on the market too that are not covered, so patients would have to pay out of pocket. But things like these ones, these are a medical grade silicone, and you can see that they're quite tapered at the one end and quite flexible. And so it really, again, depends on what the patient is going to find helpful. Just like any other kind of exercise program or rehab program, there really needs to be diligent use of dilation. And so it needs to happen a few times a week for about 10 minutes per session. Memorial Sloan Kettering Cancer Center in New York City has a great handout on how to use a vaginal dilator. And again, patients can also use a vibrator to dilate with or without the vibrating function. There was a study, they called them vibrating wands. They didn't call them vibrators, that was looking at the benefits and comparing the vibrating wands to standard dilators with the theory that the vibration might improve blood flow to the tissues, and that might help heal the tissues more rapidly than just using a non-vibrating dilator. The study was stopped early because of accrual issues. But theoretically, you can understand how that might make sense, that the vibration might help to improve blood flow, might help with healing. And heck, there might be some pleasurable aspects of vibration as well. So there's lots of different vibrators on the market as well. So there's, different ones. Again, we would encourage patients to use something that's tapered at the one end, so it's a little easier for insertion. But certainly they come in all shapes and sizes. There's something even called the guibrator for men that can be used with a semi-flaccid or flaccid penis even. And again, emphasizing to men that you don't need an erection for orgasm, so you could use the guibrator with the vibrating function to help with stimulation and eventually potentially orgasm. So yeah, lots of different devices on the market, certainly for patients. Pelvic floor physio, I think, is also really important, and not just for patients with pelvic radiation, but certainly postmenopausal type changes with that loss of estrogen and loss of elasticity. Pelvic floor, we would see quite a bit in our clinic, pelvic floor hypertonicity, where the muscles were quite tight. So this is where we'd recommend patients see a pelvic floor physiotherapist. This is somebody with expertise and training specifically for pelvic floor physio. Again, the coverage for these kinds of treatments, physiotherapy and such, varies and typically is not covered by provincial health plans. It would be third-party insurance that patients would have to use for these kinds of things, but can be very, very effective. Something we heard a lot of, and again, in the context of graft versus host disease, where there can be significant foreshortening of the vaginal canal, where it can be quite a bit, shorter and tighter and even girth-wise after graft versus host disease, or even after loss of estrogen. A lot of patients would talk about something called collision dyspareunia, where they would feel their partner almost hitting up against something, or that depth of penetration would be uncomfortable. There's something called the O-nut. I don't know if you can see that there, O-nut. And it is a medical grade silicone series of these stackable rings that can be placed at the base of the partner's penis that can then control depth of penetration. So you can see if you put a number of these on, then depth of penetration can be controlled so that the partner isn't penetrating as deeply. You can achieve that also by placing a hand or a folded towel or something in between the partners so that depth of penetration is controlled to some degree. But this would allow for, it to be a little bit more consistently. You can imagine it with a towel or a hand, it might slip out of place. These can be placed on the base of the penis and really help with that depth of penetration. I'll speak briefly here about hormone use after cancer. We know that some cancers grow in the presence of hormones, and so manipulating that hormonal environment offers a potential therapeutic option. In the context of blood cancers, we wouldn't see that this is necessarily a concern, except that we sometimes do see secondary malignancies, secondary blood cancers, in particular, some types of leukemia we'll see after treatment for, say, for example, breast cancer. And that primary breast cancer might be hormone receptor positive. So we have to be mindful about any potential contraindications in that context. So this is just an example of how we would manipulate that hormonal environment. So for patients with breast cancer, we can use selective estrogen receptor modulators or aromatase inhibitors to manipulate that hormonal environment. And so the SERMs, or selective estrogen receptor modulators, block estrogen at the receptor site. So that's things like tamoxifen are blocking right at the receptor site. In contrast, aromatase inhibitors block the conversion of androgens into estrogens. That becomes important when we're looking at using exogenous hormones for patients after a hormone receptor positive cancer. In our clinic, we did find the use of local estrogen therapy. So this is vulvovaginal estrogen. So again, not just in the vagina, but also treating the vulvar tissues and the opening to the vagina and the clitoral area. And anybody using hormones of any kind, really, the mantra now is to use the lowest dose for the shortest duration possible. But really, the local estrogen is thought to be, I will say, relatively safe, in that we know that there can still be some systemic exposure. So some of the local vaginal estrogen can make its way into the bloodstream. Not a huge amount, but it is still possible. So if there's concerns about a hormone receptor positive cancer, we would want to really counsel the patient on the risks and benefits. But they can be very, very helpful at relieving vulvovaginal symptoms. I will say this is Vagifem here, this picture at the bottom of the screen. And I would see these amazing, healthy looking vaginas, especially the upper part of the vagina, because when you insert this with the applicator, that tablet goes to the top of the vagina. But the vulvar tissues and the opening to the vagina didn't always look as healthy, because that tablet was really effective at treating that upper part of the vagina, but not the lower part necessarily. So sometimes we'd also use a low dose estradiol or estrogen cream on the vulvar tissues and the opening to the vagina. newish in Canada, approved really in the last couple of years. So we have prosterone or Interosa. It's a plant-derived DHEA or dehydroepiandrosterone. It's a mouthful. It's an intermediate in the biosynthesis of androgens and estrogens, converted by vaginal mucosal cells to estrogens and androgens. Not considered to be an absolute contraindication in women with breast cancer. But again, this would be something where we'd have careful discussions and conversations about potential risks and benefits. Osphena or ospemifene is a selective estrogen receptor modulator. It's got agonist and antagonist activity for estrogen. And in preclinical models of breast cancer, it seems to actually have an anti-estrogenic effect. But we really have very few studies to really look at the overall risk aside from the preclinical models. So again, I would be very careful and want to talk to patients about risks and benefits. And then we've got Imvexxy, which is estradiol, and it comes in very low doses, I would say, relatively, so 4 micrograms and 10 micrograms, and it is used intravaginally, and it can be very helpful for vulvovaginal atrophy and symptoms after menopause. I don't like the marketing of some of these products in some ways, so I will just say that I don't like that they use these shriveled dried flowers, but that's just my personal preference that I would like to see. I think you can imagine if there was a similar kind of marketing for men with erectile issues, I don't think it would go over that well. But anyway, that's just my little soapbox there. But I will say that these various different products are available on the market now. And each, as with any meds, comes with their own risks and benefits. So important to talk to patients about that. This paper came out a couple of years ago, 4 years ago now, I guess, or almost 5 years ago. The management of genitourinary syndrome of menopause in women with or at high risk for breast cancer. Again, overall, basically saying that the risk with local vaginal estrogens is thought to be quite low. We won't ever say necessarily that the risk is zero, but the risk for that local vaginal estrogen is thought to be quite low. So if there's a patient with a secondary leukemia, for example, after primary hormone receptor positive breast cancer, these are things where we would have these conversations with the patients about potential risks and benefits about using vaginal estrogen. This is the American College of Obstetricians and Gynecologists came out with a similar paper in 2021, talking about the various non-hormonal approaches, which is what we'd always start with first. And if those aren't working, then we can talk about the local vaginal estrogen as an approach, or DHEA or ospemifene. Laser therapy has received quite a bit of attention and a lot of marketing. So how this would work is delivering this gentle fractional carbon dioxide laser energy to the vaginal tissues, and then that's thought to kind of result in increased vascularization and growth of new cells and new tissue that might then lead to improved vulvovaginal health and lubrication and such. We don't have a lot of evidence from good randomized clinical trials to say that this is necessarily safe or effective. The concern I would say with this is it can be very, very expensive, in the neighborhood of several $1,000s, and can cause vaginal scarring, vaginal lacerations, and persistent or worsening dyspareunia or painful intercourse. So just to say, and this is Jennifer Gunter, who's a gynecologist. She's from Winnipeg, I believe, originally, but she's in the US now, but does a lot of talks and educational and vulvovaginal health. And, just to say to use these kinds of products with caution, because we don't as yet have any good evidence to suggest that these would be necessarily safe or effective. And so for us in our clinic, we would start with our other approaches first, because we do have some evidence for those. I think that's all I need to say about that laser for now. Safer sex, of course, I think is relevant for a lot of our patients. And, post bone marrow or stem cell transplantation, I've had patients say, can I ever have sex again, or do I have to abstain for a year or more? We know that, there can be partner exposure to chemotherapeutic agents. There haven't been great studies on this, and you can imagine why. There's so many different types of chemotherapeutic agents. We use a lot of them in combination. We use some of them in multi-day regimens. And so it'd be very difficult to study these and come up with any certain recommendations for patients. But we do know that there can be some of these medications that can make their way into semen or vaginal secretions, and therefore partners could be potentially exposed. What the clinical significance of that exposure is, I think, remains to be elucidated. The risk is probably very low. With that being said, we do know that some of the medications we use are teratogenic. And so we caution patients against getting pregnant or impregnating somebody if they're on medications such as, lenalidomide or thalidomide, which we sometimes see used in multiple myeloma and other types of blood cancers. I think we talk to patients about using condoms for, at least 2 or 3 days after chemo. We know that most chemo is excreted out of the body within a few days. This becomes a little bit more problematic or difficult for patients who are on oral daily chemo indefinitely. So again, we would talk to the individual patient and couple about their own risks and mitigating risks in that context. When platelets are low, we know that there can be potential for increased bleeding and bruising. When neutrophils and white count are low, there can be increased potential for infection. So, even things like anal intercourse or rough intercourse, we would worry and caution patients about the potential outcomes or consequences if their platelets and neutrophils are very, very low. But for the most part, sexual activity does not need to be avoided altogether during or after cancer treatment. We always caution patients to use safe sex practices if they're engaging in activity with a partner whose background isn't known, or if there's concerns about sexually transmitted infections. So just to summarize again, and this slide, this diagram was created in the context of prostate cancer, but I think it applies really to any type of cancer diagnosis, that there are lots of different ways to preserve intimacy, and it might not be physical or sexual intimacy. That could be a part of it for sure, but the relational, emotional intimacy, there's lots of different things we can do to help preserve that. And then we can talk about erection independent sex. So there's lots of different things that can be done if erectile function continues to be an issue, or if we can't get erectile function back to where it is amenable to penetrative sexual activity. And then, of course, erection dependent sex with the various different interventions we can prescribe. But there is always a place for physical intimacy and relational intimacy. And these are places where sometimes patients and their partners need help with this. So take-home messages, I would say that it's very common for changes in sexuality to happen after a cancer diagnosis for both the patient and the partner. There's lots of different things we can do to help improve sexual function after a cancer diagnosis. There's really no right amount of desire, no perfect relationship, and no such thing as a normal sex life. So, we really have to work with patients about what is right for them and what their goals and wishes are, and set aside any biases or thoughts that we might have about what, the right amount of sexual activity or a normal sex life might look like. Really, it is the patient and the partner that are the experts in this area, and they're the ones that can really guide how this unfolds. There are lots of different books available, some that are really excellent. Many of these on the screen, I would say, are excellent. The Canadian Cancer Society handout, which many of the cancer centers have, is quite a comprehensive booklet that talks about a lot of what I've discussed in this presentation. And then to give patients websites, I always write down or give them the exact website address, because if you type sex into a Google search, you might end up with some interesting websites that you may not want to actually be looking at. So I would say just to be cautious and give patients direct website addresses if possible. There are resources for the LGBTQ population as well. And some of these are Canadian resources, and they're fantastic. And I will stop there, but certainly invite anybody who's viewed either part 1 or part 2 or both of these presentations to email me or get in touch if I can help with any questions you may have or direct you to additional resources that you might find helpful. So thanks so much for your attention and for choosing to learn more about this very important topic. Thank you.
Thank you so much, Reanne, for this great training. If you'd like to learn more about how to support your patients or caregivers, head over to our continuing education platform to view other training available. The first part of this training, Optimizing Sexual Health and Intimacy After a Cancer Diagnosis, reviewed the concept of sexuality in the context of cancer and the potential impact of cancer and its treatment on sexual health and intimacy. We also have 2 units available to support the LGBTQ2+ community offered by Queering Cancer, providing inclusive care for LGBTQ2+ people affected by cancer. Unit 1 is about background and terminology, and Unit 2 about clinical practice. Don't hesitate to visit www.bloodcancercontinuingeducation.ca for more information. And finally, I'd like to remind you that we are here for the blood cancer community. We can help those affected by blood cancer to cope with every step along their experience. You can order material to refer your patients and their families to our services easily. Thank you and stay safe.